Next speaker, Carolina, will do the introduction. Yes, that was really great.
Thank you so much, Dr. Ali. So let's welcome all warmly Dr. Lora Bankova, Assistant Professor of Medicine, Division of Allergy and Clinical Immunology, Jeff and Penn Vink Center for Translational Immunology Research, and Birkham and Women's Hospital Professor.
Okay, hi. So I am actually not an otolaryngologist, and I'm not an olfactory specialist, but I'm a physician, and I'm an immunologist. That's how the Jeff and Vinny Pennick of translational immunology comes into play here. And some of my research was on asthma prior to COVID, and there's a specific type of epithelial cell that responds to allergens, and we found that there are a lot of these cells in the olfactory mucosa. And then COVID struck, and I'm a physician, so one of my coworkers said, why don't you, since you're studying olfactory responses to allergens in mouse models, why don't you start seeing patients who have lost their sense of smell from COVID? And Dr. Lee wasn't with us at the time yet at the Brigham, so it was sort of like an open field, and I said, why not? And that sort of led me into a completely different direction from what I was initially doing in my lab and what I intended to do, but it's been a lot of fun, and sort of thinking about it without having the preconceived notions of training in olfactory disorders. So this is how this whole thing started. The early days of COVID, right? I was studying like olfactory responses to allergens, and then all of these studies started coming up, showing that between 70 and 90% of patients with COVID are losing their sense of smell, which was interesting, and we thought they would recover. Like most viral syndromes, people lose their sense of smell because they're congested, and then it comes back. But then some of these longitudinal studies started showing in green here that 26% of people were still not recovering 14 days later. Or then people took it out to 76 days, and like 45% of people hadn't recovered at 76 days. And then finally, the data started trickling in that 2 to 4% of people actually never gain their sense of smell back at like 3 to 6 months. That's when we started getting interested in that, and fortuitously, when our study was approved by the IRB, there was a little CBS segment on our study, so all of a sudden we got tons of patients enrolled in what we call our registry study. So this is just a study where we have patients fill out online questionnaires, because what I was hearing in my clinic, was that people were frustrated that they're not being heard, that a lot of physicians their primary care physicians tell them, oh, this is all gonna go away, and they wanted to share their experience so that others can benefit from that. So we currently have 580 participants in this online registry, where we collect longitudinally the data on how people smell things in their environment, and this questionnaire was built based on what patients had told us in the clinic. So we have some interesting data here. We have patients from all over the US, and at this point we have analyzed 281 of those 580 entries, and you can see that this is, each dot here is a patient, and this is the duration of their smell loss. You can see that we have people who are 30 months out still can't smell. So what have we found is unique about this disorder? So the first big thing that Dr. Lee was talking about is like there's this well-characterized syndrome of inflammation with nasal polyps, like a lot of inflammation in the nose where you can't smell because your nose is stuffed up. But what people were telling me in clinic, my patients were telling me in clinic, is like, I'm not stuffed up. When I've talked to Dr. Lee and Dr. Roditi, another ENT surgeon, they say, oh, when you send us these patients, or patients come to us, when we look in their nose is not congested. There's no evidence of inflammation there. Their olfactory cleft, where the olfactory organ is, looks totally normal. So we wanted to look into that in a more like scientific way, like how do we measure that? And one way of measuring that is this sinonasal outcome test. It's just a questionnaire, but it's very focused on questions about inflammation in the nose, like is your nose congested? Do you have a runny nose? Do you have a postnasal drip? Do you sneeze frequently? So we asked in this online registry the patients to answer, like our participants to answer this question. So this is what we got. And normal is 20 on this score. So if you are a normal person, you score between 0 and 20, even if you don't have any symptoms. If you are somebody like, and Stella knows this better, if you're somebody who has a lot of nasal inflammation and that's why you can't smell, you normally get a score of about 50. In our study cohort, the average score is about 25. And just as a side note, all of these people here are people who had COVID, lost their sense of smell, like the high scorers, lost their sense of smell because of COVID, but also happen to have chronic nasal inflammation from allergies, because we don't exclude these people. So these are the specific questions on this questionnaire, and if you look down here at the bottom, these are the questions that I was talking about, like need to blow nose, sneezing, ear fullness, runny nose. So the take-home message here is that chronic inflammation is not the reason why people lose their sense of smell. So what are some of the unique things that, not generally sense of smell from COVID. So what are some of the unique characteristics that we found through this questionnaire, online questionnaire? So really interesting. Everybody here talks about like these, except for Dr. Cole, who talked about bad industry smells. But when we talk about smells, we think about the pleasant smells, right? So can you smell rose, or can you smell eucalyptus, or can you smell cloves? But what people are telling us, and in yellow here, the people are the answers that say we cannot smell that, and this is based on the 300 people that we've analyzed. So the things that pop up at the top of the as the top positive answers, this is what I cannot smell, are actually unpleasant smells. So it's like rancid food, body odors. Body odor smell seems to be the last one to come back. Even in people who say, my sense of smell is back, and if we specifically ask them, can you smell body odors? Can you smell your husband? They're like, no. So rancid food, burnt food, gas, all these unpleasant smells appear to be the ones that are the most affected. But they're also our defense, like our way to go around the world and not stick your nose into something that's unpleasant. And that's why I was asking the question of like, okay, so if you can't smell infection, like is there a way to think about it in the age of COVID? Like can we use other methods to be certain that you can protect yourself because you've lost this protective mechanism of smelling dangerous stuff in the environment. And then you see like citrus and mint, and the more pleasant stuff is pretty far down the list of what people say they've lost. And then the other thing that I found really interesting is that our study participants were telling us that they can generally like sort of smell, but they really have to focus hard to smell, and that's what gets at like the EEG future in measuring smell. Like it's not like they say I have a good days and bad days, and it's not that I can't smell at all, but I can't smell. I can't tell the difference between between lemon and lime, which I was able to do before. Or if I eat a muffin, I can't tell if it's chocolate muffin or vanilla muffin. I know it's sweet, I know it's a muffin, but if I close my eyes and I don't see the color, I don't know which one it is. So faint smells disappear quickly, and then the phantom smells and strong smells inducing unpleasant sensations is what Dr. Lee already referred to, and I think that's sort of all over the lay literature. Like journalists have written a lot about it, but I think the fact that people have to focus so hard in order to smell has not gained as much attention. And then this is our objective sense measurement of smell that we did in a sub-cohort of people who were from Boston and were able to come to our study center. And when we did this study, mostly done by Dante Minichetti, who's here in the audience, one of the research technicians who's been like driving this, we noticed that the first column are healthy controls, where we get a normal score on this standardized upset test. And the normal score is about between 30 and 40. And then when we measured the loss of smell in our COVID anosmia patients, it was lower, but we were surprised that it wasn't drastically lower. So a huge majority of them measured in the normal range. And then this is what congenital anosmia would measure at, like much lower where you would expect it to be. So we started wondering why that is. And a lot of our study participants told us that they find this very frustrating because they wanted to be told that they wanted their syndrome to be validated by us and for us to tell them, like, yeah, you really can't smell, and yet they scored decent on the smell test, and they started wondering if that's all in their head. And we don't think it is, for several reasons. One, Dante went ahead and asked people on the smell test to actually write down what they smelled before they circled the answer. So here, something that was somebody smelled lilac, it was, yes, it is lilac, the real answer, but what this person smelled was something perfumey, and she knew that it wasn't chili, coconut, or whiskey, so she circled lilac. Then this rose one smells none of those, but there's no option on this test to say can't smell anything, so they circled something. This person smelled rose, but it's actually gasoline. And then there's also no option to indicate unpleasant smells, which is important in this population of patients. So this person said, I smelled rotten flesh. What this actually was cheddar cheese. So we're trying to collect that information, but it is hard when you don't have like an objective measurement tool. And overall, what I'm hearing all the time is like, do I really have loss of smell? Is it really in my head? Because people keep hearing that, like, okay, it's going to go away, and maybe it's not real, and maybe you can smell fine. So we did I'm an immunologist, so I was like, okay, this is all interesting, but I want to understand the mechanism of all of this. So we asked all of our study participants who came to do the smell and taste test, they swabbed their nose and with this just regular like brush, and we submitted data for RNA sequencing. We also collected like fluid, and we did some protein and lipid mediator analysis. But so far, the transcriptional analysis is where some of our interesting things are coming out. And here is when we did this and we compared our healthy controls. Oh, you can't see this, sorry. I will explain what's what because this got cut off. So this column here are our healthy controls. These are the people who objectively have loss of smell based on the upset test. And these are the people who have normal upset test, but they perceive themselves as people who have lost their sense of smell. And you can see that the two groups, whether they measured abnormal on the smell test or not, transcriptionally look very similar. And for purposes of time, I didn't include that, but I can just tell you that this is also very different from people who lost their sense of taste, not their sense of smell, and can't on this test. So it's specific to the loss of smell. It's not that everyone who had COVID has these transcriptional changes. We have compared them to people who have recovered and people who lost their sense of taste. And this is specific to people who have lost their sense of smell. So we think that there is a true transcriptional change in the nose. There's some process that's very specific to people who have lost their sense of smell. And unfortunately, the current methods of measuring smell are not able to detect that very reliably. So persistent smell loss is not that uncommon. So if you think of how many people have had COVID, if only 2% have persistent loss of smell, that's pretty significant. I think it's very important that what people can't smell are unpleasant odors, gas, burning stuff, because these are our defense mechanisms that protect us in the world around us. And then there's these unique smell disturbances that current methods of testing don't detect very well, and would be great if we can hear feedback from you about what can be done in the future to measure this. And I think it also can inform how to do measurements of smells. Like if we use these patients as artificial noses of like, what is it what olfactory receptors are differently expressed in these people that make them not be able to smell body odors as opposed, but they can smell roses is also very interesting. And these are pictures of the cells that I studied, the tuft cells, that took me in this direction. And obviously, I want to acknowledge Dante and Caitlin, who came here to this conference from my lab. They're sitting there with their masks. And Stella, who's been a great collaborator and teaching me about the nose and the sense of smell. Thank you.
There we go. Do you have questions? Go ahead. There you go. I don't think that's on. Yeah, it's on.
Hello? Yeah, it's on. Thank you very much for your talk. It was really, really cool. I had a question about the transcriptional profile that you did. So you were swabbing the, you're doing kind of a nasal swab, so you're basically getting transcription factors, I'm assuming, from kind of like the mucous membrane, yeah, so just like the mucousy sort of part of the nose. I don't know what the actual technical term is. So is it known that those transcription factors that you were showing on the slide are actually related to smell as opposed to just some general upregulation or downregulation that has to do with like the disease itself?
Yeah. Sorry, I should probably go over here. No, it's okay. Oh, no. I will just. So that's a great question. And Stella and I hopefully will dive straight into it. The majority of what we're getting are not olfactory receptor and olfactory receptor related signaling molecules. When we've tried analyzing what we actually get in this transcriptional profile, because it's all cells, like whatever comes off, we're getting a lot of immune cells. It's actually interesting because if we treat these people with steroids, their sense of smell doesn't come back, like most disorders with loss of smell from inflammation. But there is an immune profile there. So what Stella and I are hoping to do going forward is actually to have Stella in the clinic swab directly the olfactory cleft, so we can compare what happens in the olfactory organ versus what happens when like in the lower part of the nose. I honestly have to say we didn't expect to find very much in these, like people swab their nose themselves, but surprisingly there is a difference, and it's mostly inflammatory cells that are different there.
Thank you.
Can I ask, if you join the panel at the end of this? Because you're relevant to the olfactory receptor more so than probably anyone here. So we will have a panel after this asking the two doctors and the proper anosmic that I'm about to introduce now.